Hello, this is Dr. Oscar Hernandez, board-certified internist and pediatrician. We're putting together a series of short videos about coronavirus that many of you have given us good thumbs up on, so we're grateful for that. We love the feedback. Guess what? You can tell probably by the background that I'm back home again, because I live in two places essentially, and that's in the trench, which is my office where I see patients and so on, and here at home where we try to practice self-isolation with my wife and my children. Today I want to talk about something that's very important because there's a lot of hype and a lot of concern in the community, and I live in Miami, and we've had a big outbreak in the county in which I live, and in our state it's been very much affected by coronavirus. As of today, April 11th, we have about 17,000 cases in the state of Florida, and unfortunately over 400 deaths, 419 as of the posting today at the Florida Department of Health website. So this is a real problem, folks. If you can stay at home, that's fine. If you're going cuckoo bonkers because you're cooped up at home, put your mask on, go outside, go for a walk, take the kids for a drive. Let me make something perfectly clear. There's no evidence that going out for a car drive, seeing the trees, looking at the hood, driving by other people, seeing something other than your four walls is going to get you in contact with coronavirus. So, there's a difference between prudence and panic. And so if you're inside the house and you're afraid to go out because the boogie virus is going to get you, that's probably not going to happen. Which brings me to one of today's topics. And today I want to talk about two things in particular. I want to again frame this pandemic in terms that are a little bit more within the grasp of everybody and the general public. And we're going to talk again, even though don't throw a shoe at your computer or your screen. We're going to talk about how this pandemic compares to an outbreak of flu. So put the hammers down. And let's listen to what I have to say about this, because this comes from an editorial that was published in the New England Journal of Medicine on February 28 of 2020. It was then updated on March 26 of 2020. Guess who writes this editorial? It's Anthony Fauci, Clifford Lane, and Robert Redfield. These are reputable contributors to the New England Journal of Medicine. And this is an editorial. Let me give you one of the excerpts from this editorial. I want to read it because I want to make sure that we get it right. And this is part of the editorial. You can read the full one if you want. It's online. You can find it. There's no cost involved. This suggests, the data that they've presented, that the overall clinical consequences of COVID-19 may ultimately be more akin to those of severe seasonal influenza, which has a case fatality rate of approximately 0.1%, or a pandemic influenza similar to those in 1957 and 1968. They're not talking about the Spanish flu now, they're talking about other flu pandemics, rather than a disease similar to SARS or MERS, which were other coronavirus infections that many of our listeners already know about, which had case fatality rates of 10% and 36% respectively. Put this in context. When SARS and MERS was out there, it didn't hit our country that hard, but we were not as freaked out as we are now. Now, why do we see this lower case fatality rate, among other reasons? Well, because hopefully we're practicing the things that we've been told to do. The hand washing, the hygiene, the sneezing, the avoiding social contact when it's not necessary. All of these types of things hopefully are what ultimately, as Fauci and Redfield and Long suggest, ultimately, not now, but ultimately will bring down the mortality rate to something that is similar to those types of outbreaks and pandemics, for which we have generally feared a whole lot less than we are fearing for right now. This is not to underestimate 419 deaths that I already talked about at the beginning of this video. Well, let me give you a bright spot in the whole game of coronavirus. This is based on an article from the New England Journal of Medicine that came out April 10th, 2020. That's yesterday. This is fresh off the press kind of stuff. And it has to do with a drug named Remdesivir. Don't look for it on pdr.net. You're not going to find it. It's not available in the United States yet. If you are a person who loves investments, Gilead Pharmaceuticals is the maker of this medication. And it's not the end-all study about Remdesivir, but here's what this particular study says. I'm going to read off of my notes. And again, New England Journal of Medicine, April 10th, 2020. You can find it yourself. This is an article by Green and Omagny and others. It meant multiple authors were involved. What does remdesivir do? It inhibits viral RNA polymerase. Technical stuff, but basically what it does is it keeps the virus from replicating. It poisons the virus, okay? So in day-to-day speak, it's just bad juju for this virus. 53 patients were followed in this study. Now, these are studies that need to be repeated and looked at in larger numbers of people. But 53 patients were included in this study who had oxygen concentrations under 92% on room air or on oxygen. They were given a 10-day trial of this medication under a compassionate use protocol. On day 1, they got 200 milligrams IV of this medication. It's not a pill. It's currently in intravenous form. Then they were given 100 milligrams every day thereafter for a total of 10 days of treatment. And these patients were followed for approximately 18 days out to see what would happen. Well, sadly, 7 of those patients, 13% of the 53 patients that were included, died. They did not get better with this drug, but many did. And let's look at those numbers. 30 patients were on ventilators at the time that they started this medication. 57%, more than half of those patients, were extubated while on the medication. 17 people got better and were able to be extubated off the vent while on this medication or during the 18 days of follow-up. 25 patients, 47% of those treated, were discharged within the 18 days. That's very good, right? I mean, you're home. That means that you're able to carry about some of your activities, convalesce at home, and now you're no longer sick enough to be in the hospital. Hooray, that's what we want. And sadly, 7% did not get better and expired. Of these patients, 22 were in the United States of America, 22 were followed in Europe and Canada, and 7 were followed in Japan. So an international effort and very good initial results. Does this take away from hydrochloroquine, which is currently available? No, not really. Remember, hydrochloroquine by the FDA has been approved under a SUA, a special use authorization, and it is indicated for patients who are hospitalized. Now, myself as a clinician, I have access to hydrochloroquine and azithromycin, a combination that I use based on other studies that we previously mentioned in these videos, and I use them very, very sparingly. I think I've treated 2 patients with that on an outpatient basis. Not approved at this time for an outpatient setting, but here's my thinking about this. If I have a patient who has tested positive for COVID, and maybe they weren't too sick, but I'm following these patients every day or 2 by phone, and they're telling me that they're getting worse, and I can hear them in the background hacking, and they're not breathing as they were before, I'm not going to wait until they're in the hospital. I'm going to write the prescription, start the treatment, and continue to monitor these patients, and if they have to go to the hospital, they're already on the drugs. Hey, it's not perfect, but it's what we have right now. So remember, remdesivir is on the horizon. We're going to talk about an update on vaccinations and the development of the vaccine for COVID-19 on our next program. If you like us, give us our thumbs up. Remember, I'll tell you again, subscribe. It's the best way to get these videos as soon as they come out. They're short, they're to the point, and hopefully we're driving short messages into your home about things that you can use, that you can do, and that you shouldn't do, because there's a lot of confusion out there. Before I leave you, I want to remind you of one more thing. If you're a person of faith, hang on to your faith. Help it grow. Let me tell you, it helps me phenomenally through my life. I want to reflect a moment on the words of Isaiah. And if you're not a person of faith, this is still great wisdom that you can look at and digest and wonder if you want to touch base with your own faith tendencies. And these words were written hundreds and hundreds of years ago to the children of Israel at a moment that was very tough in their existence because they were about to be taken through the Babylonian captivity. And this is what Isaiah writes. And these are the words that God gave him so many hundreds and hundreds of years ago. And speaking to people of faith, it says, but listen now. This is from the New International Version. But it says, but listen now. Listen now. Don't listen later. Listen now. This is the moment of action. This is what the Lord says. He who created you, you, Jacob, he who formed you, Israel. Do not fear, for I have redeemed you. I have summoned you by name, and you are mine. So if you're a person of faith, and you hang on to these words, and you know that you have been redeemed, that your sin, your trouble, your misery has been changed for something in eternity, that is better than what we have here. That is a great, great promise that God gives you. And if you know that you belong to your Creator, then you know that you're under His protection both here and in the hereafter. If you're a person of faith, hang on to those words. If you're a person who's not in touch with their faith, think about revisiting that part of yourself, because I know that it's in there somewhere. Great words of wisdom for people of all ages and from all paths of life and from all faiths. We're going to come back very soon. We're going to talk about vaccines. Thanks for listening. We'll be back.